Good morning, guys. Welcome to the vlog. I'm starting today in my room. I got up a little earlier just so I could knock out my UWorld questions now instead of trying to knock them out after I come home from work and I'm exhausted, you know? Okay, so I woke up earlier, was able to start my UWorld block, but wasn't able to review everything, so still not enough time in the morning. That's fine, we're learning. Walking with my breakfast sandwich. What was I gonna say? Oh, I got a text message from my chief. Oh, if you guys didn't know, oh God, my sandwich. Each rotation typically has a chief student. I really didn't have one in peds or family outpatient, but so far my inpatient rotations have had a chief, and honestly, I don't really know how that student gets assigned or elected. It's not like we vote, so I'm not really sure how that goes down. The chief for surgery for my rotation right now is assigning new patients. So whenever a new patient, like she goes to the hospital a lot earlier than we do, maybe 30, I don't know how far ahead of me she's at the hospital, but she gets the list of the new patients and assigns them to us. So I know that I'm picking up a patient who is in the CCU, so already a critical case. They were admitted yesterday, so I have to read up on that. The only summary I got is that they came in with complaints of abdominal pain. So complaints of abdominal pain and ending up in the CCU, I really gotta read what happened. I took a quick look at the vitals. They were tachycardic, but everything else I believe was in normal range. So tachycardic just means your heart rate is fast, above 100 beats per minute. Oh, they were also tachypnic, I remember that. Tachypnic is breathing fast. They were about 35, I believe, but heading to the hospital now to write up a quick note. It's not going to be a progress note, it's my first note ever. So really quick based on the admission, and I'm going to go to the CCU, take a look at the patient. Really doesn't make sense to write up a note if you haven't actually placed eyes on your patient to know what you're talking about. Alrighty guys, it's about 12:15, 12:30. I forgot my watch today, so I don't really know. We had sign-out rounds as usual. We had a vascular surgery clinic today, so we saw a lot of post-op people who had surgery in the hospital when they were admitted. They've been discharged and they came to just have a post-op check. There's some people, the patient I saw in particular came for a PVD eval, which is peripheral vascular disease evaluation. So she says that she's from a nursing home. She has a history of schizophrenia. So her history, like whenever you take a history from someone with a mental disorder, you're not exactly sure what you can and cannot believe. This is loud probably. She did have bilateral swelling in her legs, more swelling in the left than the right, and the left was more red than the right. It was like 2+ pitting edema on the left. Pitting edema is when you stick your thumb into someone's leg. That sounds weird. When you push on someone's leg and like kind of sort of squeeze it with your thumb, and your thumb leaves an imprint in their skin. So how deep that imprint is how we measure it. So 2+ is worse than 1+. She had 2+ on the left, 1+ on the right. Yeah, did a heart, lung, and abdomen. You do that always, by the way. I know I talk about like ortho clinic, vascular clinic, but always when you do a physical exam, heart, lung, abdomen, and then the focus for why they came there to the clinic. Hey guys, it is 4:38. I'm home, still waiting for a sign out from the hospital. Doing UWorld while periodically checking on my patient. Okay, let's do one thing at a time. So I'll have like a title of the topic that I'm talking about, and I'll separate it as cause, findings, test, and treat. That's basically how I've been going through the entire book of notes. So the cause of whatever I'm talking about, the etiology, or maybe the pathophys, depending. The findings would be like symptoms. The test would be if I actually ran a test or drew labs. So what would the labs show me? What would a chest x-ray show me? What would ultrasound show me? And treat is how you treat it. Also within treat, I put prophylactic measures if they're relevant. So update about my patient. I told you guys all I knew about him when I went in this morning is that he had abdominal pain and then he went to the CCU, and I was like, what? So here's like very tiny 64-year-old male presents with a history of hypertension, hyperlipidemia, diabetes, cirrhosis, came into the ED due to abdominal pain. The pain is described as dull, it's diffuse, periumbilical in location, 10 out of 10 in severity, associated with multiple episodes of non-bloody, non-bilious vomiting. Non-bloody, I think is obvious. Non-bilious is like no bile in your vomit. The patient denies any similar episodes to this, and he's not an alcoholic beverage drinker. That's really important to include because the first thing I thought about when I heard about this was like, oh, it's an alcoholic. It's probably pancreatitis, and he's probably an alcoholic. Not an alcoholic. You can get pancreatitis from other ways. In this man's situation, I'm not exactly sure what the case is. They did an abdominal ultrasound, but he is morbidly obese, so they couldn't say for sure what was there and what wasn't there. They did see that the CBD was dilated, which is your common bile duct. The reason why it's dilated, I don't know. It could be sludge from the gallbladder, which is basically what it sounds like. It's like sludge, okay. Or it could be a gallstone that's blocked in the duct, which makes it dilate. I can't say what it is because the radiologist couldn't tell me what it is. Just the report was there, not the image, so I couldn't see for myself. Oh, just got a text message saying sign out in 10 minutes, so I'm gonna head to the hospital. But other things that made me for sure think pancreatitis, they did labs, and his lipase was 25,775, which is very high, and his amylase was 4,771. It's more than 3 times the normal amount. There's something called a Ranson criteria, which is how we rate the severity of pancreatitis, and he was a 4 on that scale. I can go through that scale with you, or you can check out MD Calc, which is an app I've talked about. Not a sponsor or anything like that. It's just a really quick app to calculate these things. A lot of criteria go into these things. We also did the Apache 2 score, which is like checking the necessity of ICU, I believe, and that's also an MD Calc. I'm gonna head to the hospital now so I can print out my note, and I want to run to the CCU, take a look at my patient. Again, makes no sense presenting a patient if you haven't actually looked at them. I don't want you guys to think that I just have the hookup, like someone messages me when sign out is happening. Sign out text messages go out to a group chat, so all the students know that, hey, we should be looking into our patients, we should be printing out our notes, we should be preparing the patient list for the night crew. This is possibly the first time I'm gonna end a vlog on the way to the hospital. But thanks for watching, guys. Thanks for subscribing. See you guys next time.